Sunil, can you please put that session thing on the screen here? Is it possible when I talk?
So the only person missing is Rolika.
Ma'am, we are live.
Erwin, it's nice to see you.
So good evening, everyone. Good evening, everyone. I'm Dr. Aarti Heda, session host for this session of Wills Eye Hospital Ocular Oncology Service, Tumors to the Forefront. I welcome you all to IOC 2024, 4th International Ophthalmic Conclave Conference, hosted by All India Ophthalmological Society. To lead this session, we have with us Dr. Ritika Sen. She has completed her medical education from GS Medical College and KM Hospital in Mumbai. She went on to do her post-graduation from RP Center AIMS in New Delhi, long-term clinical fellowship in ophthalmic plastic surgery and ocular oncology at the Center for Sight in Hyderabad. She completed the fellowship in the year 2021 and research fellowship in ocular oncology she has done from Wills Eye Hospital, which she completed in the year 2022. She is currently consultant ocular oncology and ophthalmic plastic surgery services at Raghunath Netralaya in Mumbai. So Dr. Mritika is going to lead this session from here. So over to you, Dr. Mritika.
Thank you, Dr. Aarti, and it gives me great pleasure to introduce our chairperson for this session. We have with us Dr. Carol Shields. She, of course, requires no introduction because we've all read about her, heard about her, and most importantly, it's her extensive amount of work that speaks for her. So whatever I say is going to be less, but I will just introduce her in few words. Dr. Carol Shields is the Director of Ocular Oncology Service at Wills Eye Hospital, Philadelphia, United States. She is also the Professor of Ophthalmology at Thomas Jefferson University and a consultant at Children's Hospital, Philadelphia. She graduated from the University of Notre Dame with highest honors, and then she went on to attend medical school at University of Pittsburgh. She's the recipient of the American Academy of Ophthalmology Honor Award and the first female ophthalmologist in the world to receive the prestigious Donders Medal for Excellence in Ophthalmology. She has topped the power list of ophthalmology numerous times, and she was also the first woman elected to be the president of the International Society of Ocular Oncology. So without further ado, I hand over the podium to Dr. Shields.
Thank you, Dr. Sen. It's a great pleasure to be here today. We have a lineup of great speakers, all of whom I've had the opportunity to work with at Wills Eye Hospital. So I think this is going to be a wonderful session on a variety of different diseases, different ocular tumors. And today we're going to totally bring tumors to the forefront, as our title says. So back to you, Dr. Sen, and you can introduce the speakers.
So first we have with us Dr. Rolika Bansal, and she is currently doing her fellowship with Dr. Shields at Wills Eye Hospital. She will be talking to us about management of diffuse choroidal hemangioma. Please go ahead, Rolika.
Thank you, Dr. Sen. Thank you, Dr. Shields, for the opportunity. And I must say thank you for training us, all of us. We're not working with you, we're getting trained with you, and we're proud to be a part of the team. Can you all see my screen?
Yes.
Is it?
Yeah, we can see your screen, Rolika. Go ahead.
Yeah, but the screen's not moving here. Just a second.
We can see the points.
All right. Okay, so I will be talking on management of diffuse choroidal hemangioma, and I thank my mentors for the opportunity. So diffuse choroidal hemangioma per se is a benign vascular hematoma, and diffuse choroidal hemangioma represents an ill-defined choroidal mass with indistinct margins, and it gives a typical tomato catsup fundus appearance, which I will be briefing you about very soon. Characteristically, it is found in the Sturge-Weber syndrome, and we will be talking about the same. And an association with sporadic mutation in GNAC or GNA11 has been noted previously. It basically occurs due to dysregulation of the mitogen-activated protein kinase, which influences the gene transcription and results in cellular proliferation. And most often, the patients present with vision loss from induced hyperopia, amblyopia, secondary retinal detachment, or macular edema. But it's not very easy to put it all together in frame. So let me exemplify it on the basis of a case scenario. So the basic treatments that are available, or the treatment modalities that are available, are as follows, as you can see, that are popping up in front of you. And I'll brief them one by one. So the case scenario is 11-year-old white female presented for a choroidal lesion with retinal detachment. What were the symptoms? Putting them together, there was blurry vision in the left eye for 2 weeks. She was a known case of Sturge-Weber syndrome, and she had a history of secondary glaucoma in the left eye since 5 years, and she was on anti-glaucoma medications. Birth history and family history were essentially irrelevant and normal in her case. On examination, as you can see over here, the left eye showed a visual acuity of 20/200, which is a significant difference from the right eye. And her pressure was essentially normal because she was on anti-glaucoma medications, and she had a typical port wine appearance, which is a characteristic finding of Sturge-Weber syndrome. So it's one of the 3 triads, and I will be talking about them one by one. So we found one, that is the port wine stain. And she did have a small capillary hemangioma on the lid, and she had episcleral vessel superiorly. As you can see over here, that this is the typical port wine stain, which is ipsilateral and was seen in her. The fundus examination showed a diffuse choroidal lesion with retinal detachment, as you can see inferiorly. And if you see the wide field imaging over here, there are specks of hemorrhage which can be seen in the periphery as well. And it's a diffuse lesion involving the macular region. And fundus autofluorescence showed a hyperfluorescent lesion with specks at the periphery, and it shows the inferior retinal detachment as well. Ultrasound showed that the tumor was involved in nearly all quadrants with variable thickness, and the thickness was maximum at 3 o'clock, which was 3.69. And as you can see over here, there was medium to high internal reflectivity on A-scan overlay. And the OCT, it showed that the macula was involved. The foveal contour is pretty much lost over here, and the lesion can be seen over here. The medium enlarged vascular channels within the choroid can be seen, but no compression of choriocapillaries were visible. Fundus autofluorescence of the right eye was normal, and the left eye showed early hyperfluorescence and with a significant late washout, which is also a typical characteristic feature of choroidal hemangioma. And the similar can be seen on ICG, which is here we can see the washout very evidently, and the visual fields correlated with the clinical findings. Putting all of them in perspective, putting one by one all the dots together, we saw that the findings were correlating and indicating to a final diagnosis of choroidal hemangioma with a Sturge-Weber syndrome and secondary glaucoma. As I spoke, that it's a triad of Sturge-Weber syndrome, and that would be secondary glaucoma, which she has, the port wine stain, which she has, and also leptomeningiomas, which were negative in her because her MRI brain that was done at baseline was normal. The treatment modalities that are available are as follows, as I enlisted earlier. Let's take them one by one. Oral propranolol. Oral propranolol has been an old standard which has been which is being used even in developing countries, as quoted long back by Thapa and Shields et al. Thapa and Shields, which said that they used oral propranolol and they started it early before the extensive retinal detachment developed. So it is ideal to use in cases where the retinal detachment has not yet developed. Photodynamic therapy has been pretty much used in worldwide, and it's quite useful because it stimulates the RPE and it reestablishes the outer retinal blood retinal barrier, and it allows the resolution of subretinal fluid and minimizes the tumor-induced foveal distortion. But it is important to know that a delayed choroidal atrophy can occur if the therapy is repeated multiple times. So it's advisable that retreatment should not be performed, as it can cause delayed choroidal atrophy. Radiation has also been attempted. As you can see over here, a paper has been very extensively quoted where they have reviewed the radiotherapy modalities. Lens-sparing modalities were used, proton beam therapy was used, and it has been pretty much successful in the cases with choroidal hemangioma. When we talk about plaque brachytherapy, it popped up as an effective alternative to photocoagulation. And over the time, it has been observed, Madhaparala et al. Have seen excellent outcomes with plaque brachytherapy, and the results are pretty much encouraging because it leads to complete and permanent resolution of subretinal fluid in these patients. And it gives the advantage over photocoagulation, where recurrence could be common. As we have already quoted, that retherapy with photodynamic therapy is not really advisable. So moving on, what would we choose for our patient over here, the case scenario that I had presented? We went ahead and chose the treatment modality to be plaque brachytherapy. And we proceeded with iodine 125 plaque brachytherapy, where 30 gray of apex dose was utilized, and 18 round full plaque with 8 seeds were utilized, and it was placed under the lateral rectus muscle to make sure that there is complete coverage of the lesion, and the conjunctiva was spared superiorly, keeping in mind that the patient has glaucoma and might require an intervention later. And she also received prophylactic anti-VEGF 4 monthly. That's the regimen that we have been using. Dr. Shields has been advocating it, and it's extremely effective. That is, we give 6 injections of anti-VEGF every 4 months. And you can see over here that this was the lesion baseline, and at 4 months, there is excellent resolution, and the vision changed all the way from 20/200 to 20/30, which is an excellent visual outcome achievement. And the foveal contour was also achieved. And at a 1 year and 4 months follow-up, she's done pretty well with the foveal contour maintained and a visual outcome of 20/30. A literature review over here can also be seen, and which shows that plaque brachytherapy has been utilized by multiple authors all the way from 1996 with multiple radioisotopes. And a similar study, as you can see, the visual outcome over here, we have been able to achieve excellent vision outcome with 20/30 with iodine. A similar paper was done in 2005 by ruthenium, where a mean tumor thickness of 5.2 was treated with a similar visual outcome, and we have been able to achieve it with the similar a similar case with iodine with complete SRF resolution. So to conclude, a tailored management is preferred depending upon age, size, and disease extent. So we must keep all of these factors in mind. Plaque radiotherapy with iodine 125 is an effective modality for diffuse choroidal hemangioma with baseline glaucoma. An apex dose of 30 gray is quite advisable. And as highlighted, we must remember that the conjunctiva sparing should be kept in mind. Anti-VEGF injections are recommended for radiation retinopathy prophylaxis, which have been highlighted. That is 6 injections with 4 months gap. A complete vision salvage and globe salvage can be achieved with plaque radiotherapy. So thank you very much.
Thank you very much, Rolika. So the audience, that when we have diffuse choroidal hemangioma, how do we go about with deciding the area of treatment and the placement of the plaque?
Right. So the area of treatment, first of all, depends on the base and the thickness of the lesion and the site of the lesion. These 3 factors have to be kept in mind. Like in the cases with diffuse choroidal hemangioma, we must remember that the base is going to be quite wide. As you can see in our case, we've chosen the plaque of 18 and it has been able to give a complete full coverage of the lesion. A radiation oncologist often goes and makes sure that the seed placement is in such a way that the entire lesion gets radiated with the apex dose being delivered adequately. So we also have to keep in mind that the fovea was pretty much in the center of this lesion. But still, with the 30 gray, we have been able to achieve a good foveal contour, and the vision was 20 by 30. So keeping all of those factors in mind, it is mandatory. If it's a peripheral lesion, of course, we are happy that we are taking care of the fovea. And in the peripheral lesions, we place the plaque according to the location of the tumor and according to how we are able to go underneath the muscle or over the muscle. So yeah, keeping all those factors in mind is mandatory.
Excellent result with this. We probably, another thing I might add, that it's the highest area of tumor thickness that we center the plaque on, because in diffuse choroidal hemangioma, it's going to be a diffuse thickening overall. So it's very difficult to determine the base as such. And Dr. Shields, do you vary the maximum dose that you treat when it comes to circumscribed or diffuse choroidal hemangiomas? Does it vary?
That's a good question. With hemangiomas, we know they're super sensitive to radiotherapy, so we can go with super low doses, somewhere between 20 and 30 gray, as Dr. Rollica mentioned, and still get control. So these patients hardly ever get radiation retinopathy. But this patient that Dr. Rollica presented had chronic retinal detachment with retinal hemorrhage. And she does have a little bit, we just saw her recently, little bit of maculopathy. I think that's more related to the VEGF level from the chronic detachment than it is from the radiation. So low dose for hemangiomas.
Right. And we still go ahead with the anti-VEGF prophylaxis, even though we are treating them with a low dose one. I think that's important to highlight.
Okay.
Thank you so much.
I mean, if I can make another point,
Yes.
PDT is nice, but PDT, in a kid to sit still for the amount of time you need to deliver it could be challenging. We use PDT as the treatment of choice for circumscribed choroidal hemangiomas, but for diffuse choroidal hemangiomas that occur in kids, we tend to use plaque radiotherapy as first choice, low dose.
Perfect. Thank you. So moving on, I'd like to invite Dr. Deepti Kurian to speak on cancers in patients with neurofibromatosis type 1. Dr. Deepti recently completed her fellowship at Wills Eye Hospital, and she's a consultant at CMC Vellore, India.
Right. Can you hear me and see my slides?
Yeah, your slides are visible. Go ahead.
All right. Thank you so much, Dr. Sen, and I'd like to thank AIOS for having me. So much in life is determined by randomness, but I thought as clinicians, you might like to take some calculated guesses. I have no financial disclosure. This is a great book that talks about chances in life, but I'm going to talk to you about chances of cancers in neurofibromatosis. And I'm trying to popularize the word rasopathy, and I'm going to say it about 17 times for chromosome 17. So NF gene is a tumor suppressor gene and codes for a protein called neurofibromin, which inhibits RAS-GTPase pathway that is responsible for cell division. And neurofibromatosis is a neurocrestopathy where there is proliferation of specifically neural crest-derived tissue. And there are many mutations that have been found for neurofibromatosis, and they have high mutation rates causing multiple hematomas, like we see in patients with neurofibromatosis. But it's been hard to explain why some patients have only few lesions compared to others who have innumerous lesions on their body. That is why it is important to know that NF is only one of many rasopathies, which include quite a few mutations that affect the RAS-MAPK pathway. We'll come to that after we take a look at this case. So this was a 60-year-old white female who was referred for an iris lesion in the left eye. She has had a history of optic nerve glioma on the right side that was treated conservatively 40 years ago. Family history was significant for neurofibromatosis in her mother. On external examination, there were subtle neurofibromas on her face and neck and cutaneous freckling over her extremities, but no major cafe au lait spots. On ocular examination, right eye had hand movements vision due to optic atrophy because of the glioma, causing a right esotropia, and 20/30 vision in the left eye. And you can see Lish nodules in both eyes and an iris mass infratemporally in the left eye. On a closer look, you see the Lish nodules. And the infratemporal mass was rather yellowish with areas of dense pigmentation. There's distorted pupil with ectropia and uvea. Gonioscopy showed pigments within the angle, which is something you will look for if you're suspecting a melanoma. Fundus exam of the right eye showed disc pallor secondary to the glioma and multiple areas of choroidal abnormalities, which is actually the most common ocular feature of neurofibromatosis, more so than Lish nodules. Fundus autofluorescence was normal. The choroidal abnormalities were seen in the left eye as well. ASOCT shows the mass with its epicenter in the iris stroma, which is derived from neural crest cells. Ultrasound biomicroscopy again showed the lesion to be arising from the iris, abutting the corneal endothelium. It had a thickness of about 3 millimeters, and there was no ciliary body involvement. So she definitely fit into the criteria for neurofibromatosis 1, with Lish nodules, family history of NF, optic nerve glioma, and cutaneous freckling. And as far as the iris lesion is concerned, is this something benign or malignant? To help us answer that question, let's look at this figure over here. We know NF is a tumor suppressor gene, which inhibits the RAS pathway. Now, NF is only one of many RASopathies. Multiple other pathways of the cell cycle intersect at the RAS-MAPK junction. And mutations at each of these points can give rise to a different syndrome, which can have clinical features very similar to each other. I brought this up to highlight the fact that there's neurofibromatosis and there are NF-like syndromes, some of which are Noonan syndrome, which has features like low set years, short stature, pulmonary stenosis, Costello syndrome, which has developmental delay, loose skin folds, cardiac issues, and Legius syndrome, probably the closest to NF. They have café au lait spots, freckling, but no neurofibromas or gliomas. All right. So it's important to know this, one, because of overlapping clinical features between syndromes. You might want to be careful while labeling a patient with a diagnosis. Two, apart from their own specific features, they are all predisposed to systemic abnormalities like cardiovascular malformations, lymphatic malformations, and guess what? Cancers. So you might say, really, do patients with neurofibromatosis often have other cancers? Let's see. This review article talks about neoplasms associated with NF mutations. So if you have germline NF mutation, like in a patient with neurofibromatosis, you're predisposed to all these different cancers like rhabdomyosarcoma, optic nerve glioma, lymphomas, carcinoids, Hodgkin's lymphoma. But it is also interesting to know that 5 to 10% of human sporadic cancers have NF1 somatic mutation. So NF gene is one of the commonest RASopathy gene mutated in cancer tissue. But going back to those with germline NF1 mutation, it is really hard to prove an association with cancer. So epidemiological studies can help, and this was a study published in 2013 where they used ICD codes to include all patients with NF in the whole of England, followed them up for subsequent admissions for cancers, and compared them to a control cohort and analyzed the risk of malignancies. And they found that the relative risk of all cancers in those with NF was about 4. And this included many malignancies of GI, breast, prostate, lymphomas, skin melanomas, and even non-melanoma skin cancers. And the relative risk was still high, about 2.7, even after excluding all CNS tumors that we know occur in NF gene mutations. Now, if you look at the eye and head neck cell tumors, the relative risk for malignant tumors was about 20, and those for benign tumors was about 12. So there is a statistical possibility of cancers in NF, but is there a biological explanation? Well, yes, since it is a RASopathy, it interferes with cell division and can cause tumors of any neural crest-derived structure, iris stroma being one of them. So, and café au lait spots are basically increased proliferation of melanocytes. And the product of NF gene, neurofibromin, regulates cell division and apparently also regulates melanoma genesis. So does NF predispose patients to melanoma? We did an FNAB on our patient, and sure enough, it was melanoma. And you see clusters of atypical spindle cells with fine melanin granules within. And on the bottom right, you see macrophages that have ingested the melanin pigment released from degenerated tumor cells. So there are about 4 previously reported cases of iris melanoma and neurofibromatosis. This is one of them where they did genetic testing. So the patient with NF and iris melanoma was found to have 2 pathogenic germline variants of NF mutation. They went a step further and did tumor genetics, and the patient was found to have no additional somatic mutation in the tumor other than the germline mutation. So the question is, did the germline NF mutation cause the iris melanoma? But his daughter, who was also a patient of neurofibromatosis, was found to have the same germline NF mutation variants, but the daughter did not have iris melanoma. So the conclusion is that a loss of NF1 protein itself might not be sufficient to drive iris melanoma, but it is likely that concurrent alterations in other RAS regulators could combine with an NF1 germline defect in driving melanoma genesis, and these could be modifier genes or second hit mutations. For now, we know that patients with NF are statistically at higher risk for melanoma, and studies on tumor genetics will provide more insights into this. These are my references. Thank you so much. I'd like to thank Dr. Shields and Dr. Lalli especially for this case, and I'll thank all our patients.
Thank you, Dr. Deepti. I think this was a very, very interesting case, highlighting all the possible tumors that can happen in patients with neurofibromatosis type 1. Dr. Shields, do you have any comments on this?
Yes, so I've been in the field of ocular oncology for 40 years, and we knew way long ago that patients with neurofibromatosis type 1 are at risk for uveal melanoma. They're at risk for congenital hypertrophy of the retinal pigment epithelium, optic nerve glioma, Lisch nodules, and then we learned a little bit later, choroidal nevi, multifocal. We never could quite tie them together, but now that we know the germline mutation, where it occurs, the RASopathies that Dr. Deepti was talking about, it starts to make a little bit more sense how Legius syndrome and Noonan syndrome and neurofibromatosis type 1 are sort of tied together by mutations. So I just think the whole field of genetics is allowing us to understand that these might not be independent diseases, but they're sort of intertwined.
You know how we always say that generally patients will not have 2 separate conditions. You have to kind of correlate, and that's, I think, all coming together with this.
Yes.
The advancement in genetics.
4 times higher rate of malignancy, according to Dr. Deepti's research.
Yes. And I think one of the most important slides that she showed was the one with multiple arrows, connecting so many genes with the different syndromes.
And Dr. Shields, as you mentioned that like a patient with an NF1 has a tendency for like say multiple choroid nevi or chubby, would you advise genetic analysis in these patients? And do you think that they have a tendency of developing the other lesions in future?
Yes, so typically if a patient has only Lisch nodules and nothing else, no skin lesions, nothing else, our genetics team will not do genetic testing if they only have one finding. But if they have more than one finding, multiple findings, we'll get genetic testing. And as Dr. Deepthi said, it's probably a result of further mutation that leads to the malignancies. And we don't know what tips off or trips those mutations. But I do think patients with NF1 need, a dilated examination annually.
Yes. Okay. So I'll go on with the next presentation then. That would be mine.
Okay, so let me introduce Dr. Mritika Sen to you. So Dr. Mritika Sen has been one of the past fellows of Dr. Carol Shields and Dr. Honavar as well. And she is currently practicing in Mumbai, and she's an excellent clinician as well as a mentor to me too. Over to you, Dr. Sen.
Thank you so much. And I'd like to thank AIOS for giving me this opportunity. So, and one second, let me just... And of course, I would like to thank my mentor, Dr. Carol Shields, for giving me this opportunity and having the faith in me to carry out this study under her. So today I'll be talking to you about the relationship between Fitzpatrick skin type and the Cancer Genome Atlas classification. So the Fitzpatrick skin type is an objective method of classification of patients on the basis of their skin color and the sensitivity to sunburn. Based on it was initially actually devised to identify the ideal dose for ultraviolet radiation for the treatment of psoriasis. And with that, we have 6 types, type 1 being white. And moving on to the darker skin colors, type 6 is black. On the basis of the minimal erythema dose, it was found that type 1 is most sensitive to sunburn, while type 6 is the one which is least sensitive. Now, we all know about the Cancer Genome Atlas. It is a DNA-based method to genetically classify uveal melanoma and help us to prognosticate melanoma-related metastasis. On the basis of the genetic studies, basically be classified into 4 TCGA types. Group 1 is the one with the best prognosis or most favorable prognosis. It has diasomy of chromosome 3 and normal 8q chromosome. B has diasomy 3 and partial gain of 8q chromosome. C and D have less favorable prognosis with monosomy 3 in C with or without gain of 8q. And in group D, there is both monosomy 3 as well as multiple gains of 8q chromosome. Now, this was actually a landmark study by Shields et al., which was published in 2021 in the Indian Journal of Ophthalmology, which actually showed that the TCGA may be more accurate in determining the prognosis for metastasis in uveal melanoma as compared to even AJCC classification. In this study, it was found that the Kaplan-Meier rate of metastasis at 5-year and 10-year was least for group A, that is 4% and 6%, and highest for group D at 60% at 5 years. So what do we already know? Well, the relative risk for cutaneous melanoma is higher for FST1, that is 2.27, as compared to FST4, and this reduces gradually for FST2 and FST3. Further, study by Shields et al. For conjunctival melanoma and its relation to FST showed that while majority of the patients with conjunctival melanoma belong to FST1 and 2, there was really no association at the 5-year rate of vision loss, tumor recurrence, globe salvage, metastasis, or death. Coming to uveal melanoma, it's also been found that aberrations in chromosome 3 and 8q have a greater impact on survival in those patients who have lighter iris. Now, other studies which have been done to determine the relationship of uveal melanoma and race and ethnicity, they have found that definitely uveal melanoma, the incidence is higher in fair-skinned individuals. Apart from that, the meta-analysis which was done by Weiss et al. Showed that lighter skin color, lighter iris color, and higher tendency to sunburn were the most important and significant host risk factors for the development of uveal melanoma. However, in the study on 8,100 patients of uveal melanoma to determine its association with race, they really did not find any significant correlation. Again, here I would want to specify that race is a self-identified term. It is also impacted by genetic, cultural, and socioeconomic conditions. Therefore, I think FST is a much more objective method of classifying patients in terms of skin color. So, in the published literature, what is the lacunae that we have? We really don't know whether Fitzpatrick's skin type affects the metastatic outcome in uveal melanoma. Does the Fitzpatrick skin type impact survival outcomes in uveal melanoma? And does Fitzpatrick skin type impact the genetic outcome in uveal melanoma? So we did these studies in 2021 and 2022 in Wills Eye Hospital, where we studied 854 consecutive patients with uveal melanoma. And we had the information on both the FST as well as the TCGA classification in order to answer these questions. So I'm going to take you through the salient findings of these two studies and figure out, is there really a relation between FST and TCGA? So coming to the demographic features, we found that patients with TCGA and FST1 presented at an older age. Also, patients with TCGA-C and FST 3, 4, and 5, they had greater incidence of melanocytosis and heterochromia. Here again, I would like to specify that we divided the patients into FST type 1, type 2, and took 3, 4, 5 together for the ease of analysis because the numbers were low. Now coming to the tumor characteristics, in group A, those patients who had FST1, mainly their tumor was arising from the choroid as compared to FST 3, 4, 5, where there were still certain patients who had tumors arising from the ciliary body and the iris. In TCGA-B, patients in the group 3, 4, 5 had a largest mean basal diameter, which was significantly higher as compared to the other two groups. Patients in group C, TCGA group C, and FST1 had a greater distance from the foveola as compared to the other two groups, and the tumors were therefore more at the periphery. And in TCGA group D, it was found that 100% of the patients belonging to FST1 had the tumor arising from the choroid. Coming to the outcomes, we evaluated the vision loss, enucleation, recurrence, uveal melanoma metastasis, and death from metastasis. And we found that there was significant difference in metastasis and death from uveal melanoma in TCGA group A, which was highest for the patients belonging to the type FST1. Coming to TCGA-C, we also found that these patients who had FST 3, 4, 5 had a higher odds ratio of death from uveal melanoma metastasis. And this is the most important table of the study. Here we found that patients with FST1 were more likely to have the highest risk cytogenetic mutation, that is TCGA group D, with an odds ratio of 2.34, while patients with FST 3, 4, 5 were more likely to have a lower risk cytogenetic mutation, TCGA group E, with an odds ratio of 2.26. When we studied the Kaplan-Meier survival analysis for metastasis and death, we found that there really was no difference at 5 years, 10 years, or 15 years for the rate of metastasis or death within each group of TCGA. But looking at this study, which was done by Negretti et al. And published in the journal I, it was found that patients with FST1, as compared to 2 or 3, 4, 5, demonstrated the greatest 10-year incidence of melanoma-related metastasis as well as death. So now I've presented all these tables and figures to you. What do they all imply? Well, patients with FST1 are more likely to have TCGA group D and therefore a higher group of tumor. FST1 patients are at substantially increased risk for melanoma-related metastasis, and it is very important to advise them to undergo genetic testing as well as to ensure very close follow-up for these patients. On the basis of the Kaplan-Meier analysis, there was no difference in the melanoma-related metastasis between FST type 1, 2, and 3, 4, 5 within each of the TCGA groups at year 5, 10, or 15. And this reinforces the fact that up till now, based on the evidence that is available, it is the genetic testing which remains more objective and a better prognostic indicator of the outcome. So finally, did we answer our questions that we began with? Does Fitzpatrick skin type impact the metastatic outcome in uveal melanoma? Yes, it does. Fitzpatrick skin type also impacts the survival in uveal melanoma. Does Fitzpatrick skin type impact the genetic outcome in uveal melanoma? I'm going to leave it at maybe at this point, simply because although we did find significant relationship between FST1 and TCGA group D, this was a single center study. Also, we really did not have patients, a large number of patients in the groups 3, 4, 5, and no patients in group C. So I think what we require now is multicentric study and further study from population where these groups are there in significant numbers. Finally, does Fitzpatrick skin type impact the metastatic and survival outcome in patients within the same TCGA group? No. This highlights the importance that we really need to advise genetic testing in all patients irrespective of their FST or the skin type, even though that may give an indication of the outcome that we can expect in these patients. Thank you very much. And this slide basically shows the people who made my life at Wills and Philadelphia significant with p-value less than 0.000001. Thank you so much.
Thank you, Dr. Sen, for that really detailed analysis of Fitzpatrick skin type and its impact on uveal melanoma outcomes. You know, in the older days, we used to use race, but as you indicated, there's a lot of intermarriage. Race is subjective, you know, and it's very hard sometimes to whittle down what exact race you are. And this is why FST has become kind of a little more important, especially in the field of dermatology. And I thought the most important finding in your studies were that patients who had the lightest skin tend to have the worst genetic findings. Mm-hmm. And I think that mirrors kind of what we see. Patients who are very, very fair skin tend to have maybe a more serious tumor.
Yes.
Dr. Ralika or anyone else, do you have anything to contribute here?
Yeah, actually, I would like to comment that that is a very interesting observation made, because I do see the patients coming in the clinic and having doubts about what it's going to be like, and you know, what's the survival is going to be like. So I think we do have answers for them, and based on this, we can actually verify that yes, genetic analysis is important. It helps us highlight the importance of genetic analysis, and even in the in cases like, you know, in developing countries where we cannot do the genetic analysis, this study gives us an a landmark where we can actually comment on it to the patient, that even if you don't have genetic analysis, yes, systemic evaluation is mandatory on a regular basis, because yes, you have a higher risk because you have a Fitzpatrick 1 or 2, and so.
Yeah, and I just would like to bring up one other point. I think genetics are very important, but I think in the future, we're going to be finding more biomarkers that are more easily accessible through a blood test or through saliva that might not necessarily be genetics. And there's a paper coming out, I'm actually writing a summary on it, from the group in Leiden, the Netherlands, and they have discovered that a biomarker in the blood called tenascin, It's going to be published in Canadian Journal of Ophthalmology, I think next month, or maybe it just came out online. But tenascin is a blood marker that can be used as a biomarker, and it can identify patients at risk for metastatic disease. Very interesting. This whole field of melanoma is kind of slowly evolving with greater understanding of who's at risk and who's not.
Yes.
Right.
All right. So I'm going to introduce the next speaker now. Dr. Shields, would you want to go ahead with your presentation first, since Dr. Feroz is not there?
Sure.
Okay, so we have with us Dr. Shields. Please go ahead.
Can you see my screen?
Yes, yes.
Okay, so I have no financial disclosures, and I would like to talk to you about Retinoblastoma 2024, therapies and outcomes. Now, this is not just my work. This is the work of many people, and you will see some familiar names in this list, like Dr. Kurian, Dr. Bonsall, Dr. Viji, Dr. Sen. We have all worked together over the past several years to bring together these outcomes for retinoblastoma. It really does take a village to manage one case of retinoblastoma, and at Wills Eye Hospital, we've been doing this for over 50 years. Let's begin with global retinoblastoma. A nice study by Cavella, BJO 2009, on the most frequent eye cancer. And guess what it was worldwide? It was retinoblastoma. There are 8,000 new cases of retinoblastoma each year on planet Earth. Melanoma came in a close second. And then Didi Fabian et al. In the global retinoblastoma study looked in 2017 at 153 countries and over 4,000 new patients with retinoblastoma. We all sent data to him. And he found that the median age at diagnosis was 30 months. But if you look at income level per country, high income countries, the median age at diagnosis was much earlier, 14 months, extrascleral retinoblastoma only 2%, and metastatic disease less than 1%. And compare that to low income countries, median age at diagnosis 30 months, extrascleral retinoblastoma nearly 50%, and metastasis nearly 20%. So if we look at this in graph form, you will see median age, 14 months in high income versus 30 months in low income countries, big disparity there. And if you look at extrascleral retinoblastoma, big disparity, 49% versus 2%, higher in low income countries, and metastatic disease higher in low income countries, 19% versus only 1%. I think much of this is related to the 16-month delay in identifying the tumor or the patient getting to the center for treatment. David and Kona Lizama, Lauren Dalvin, and I wrote a nice review in Indian Journal of Ophthalmology 2020 that goes over all these modern treatments for retinoblastoma. And what are the treatments that are available? Well, enucleation is still performed. Just last week, we enucleated an eye with retinoblastoma. We enucleate if the tumor is massive, involving the entire retina, or if there's no hope for saving the eye or vision, or if the parents are unreliable. If they're not going to come back for chemo, then we don't give chemo. Intravenous chemotherapy, we still use for bilateral disease, intraarterial chemotherapy. For unilateral disease, we inject the vitreous and aqueous if there's persistent seeding in those compartments. And yes, plaque radiotherapy still has a role in the management of retinoblastoma if all of the above fail. So let's talk about intravenous chemotherapy. This was initially introduced in 1994. The first 4 published reports came out in Archives of Ophthalmology from London, Toronto, Philadelphia, Los Angeles, and then an editorial was written. And now we have 40 years, 30 years follow-up on these patients who have received intravenous chemotherapy for retinoblastoma. We were shocked when we saw how well intravenous chemotherapy worked. It not only treats the eyes, but it can reduce the risk for pinealoblastoma and reduce the risk for metastatic disease. Here's a child we saw many years ago who had total retinal detachment and bilateral advanced retinoblastoma. After 6 cycles of intravenous chemotherapy, the retina was flat. She's now 30 years old. Her vision's 20/30, 20/70, no metastatic disease. But the question arises, is it really lasting? Like, does it last to 20 years, just giving 6 months of chemo? Well, in concert with many of our colleagues, Zainab Baz, Dr. Tadapalli from India, Dr. Dalvin from Mayo Clinic, Dr. Rao from India, and many others, we looked at long-term, 20-year, real-world outcomes of intravenous chemotherapy in nearly 1,000 eyes of children with retinoblastoma, published in BJO 2020. So this was 26 years after we had started systemic chemo. And what did we find? What we found, if you look at retinoblastoma grouped as group A, B, C, D, and E being the worst, we had very high control with the 6 cycles of intravenous chemotherapy for A, B, C, and even D at 1 year, less control for E. Then at 2 years, still good control. And the kids are off the chemo. At 3 years, good control. 5 years, good. 10 years, it maintains. And 20 years, it maintains. So basically, what we see with the 6 cycles of intravenous chemotherapy at 2 and 3 years is pretty lasting to 20 years. So in answer to that question, yes, systemic chemotherapy is lasting at 20 years. But you have to understand it's not just systemic chemotherapy. Some children will need additional intraarterial chemotherapy to control the disease. Group D and E, about 20 to 25%, need additional IAC and even additional plaque radiotherapy. About 20% need a plaque to control a tumor. We usually go to IAC first. The mean interval is 5 months. Then we go to plaque second. Mean interval is 13 months. So IAC overall is necessary in 17%, plaque in 19%. So you need to keep this in your back pocket because it will help you save more eyes. Now, I just want to make one word on iodine plaque radiotherapy for retinoblastoma recurrence following intraarterial chemotherapy. This was published JPOS, Pediatric Ophthalmology and Strabismus 2022. So we looked at these eyes and we found that if we need to use plaque radiotherapy after IAC, we have good control of solid tumor, 92% control, good control of subretinal and vitreous seeds, 100%. But that's right where we put the radiation. If seeds come up remote, then we have to do something else remotely. And most of these cases, plaque radiation was necessary because we did not get enough chemotherapy to the recurrence because it was in a bed of ischemia. So if you have an ischemic bed and you can't get IAC to that ischemic bed, then you have to do plaque radiotherapy because it does not rely on blood flow. So here we see a child before in A, then with recurrence overlying the calcified retinoblastoma. We tried IAC, it failed. So then we had to do a plaque and you can see it responded. And another case that we tried IAC, but the seeds, subretinal seeds just got larger as seen in A. So we plaqued the entire area. And this child is like 5 years follow-up, excellent control. So if IAC fails, still consider plaque radiotherapy. Managing retinoblastoma is like a game of chess. Every move counts. You have to strategize. You have to anticipate what your next move is going to be. If this treatment fails, what can you do next? You just want to outsmart your opponent and your opponent is retinoblastoma. So what about IAC? Well, we use IAC all the time. It's best for exophytic retinoblastoma. You might have a little subretinal fluid. This was a group DI and responded nicely. So IAC, intravenous chemotherapy, was introduced in 1994. IAC, our program, started in 2008. So we've had 16 years experience with intraarterial chemotherapy. We have 2 full-time neurosurgeons who perform the catheterization. They don't allow anyone in the room when they're doing it except for their nurse. But you can watch through a viewing station outside the operating room. And basically, they give it through the femoral artery up to the internal carotid artery and stop at the opening of the ophthalmic artery and squirt the chemo in, and it gets into the eye. So for unilateral retinoblastoma, this was group D, 2 doses. Again, let me repeat, look at that eye, how advanced that tumor is. And after 2 doses of melphalan, the tumor shrunk to a 4-millimeter scar, and the retina was totally flat. So we've looked and published in the Journal of the American Academy of Pediatric Ophthalmology and Strabismus 2021, 341 consecutive eyes with 1,200 infusions of intraarterial chemotherapy. Here you can see a group D exophytic retinoblastoma before and after treatment, 2 years follow-up. And we found at 5 years, we don't use it for group A, we treat focally, no chemotherapy for group A. But group B, we had 100% control, group C, 80%, D, 78% control, E, 55% control at year 5. So this is primary IAC, primary treatment. Overall, 5-year globe salvage was 76%. We used 3 different drugs, melphalan in almost every case, topotecan in nearly every case, and carboplatin only if we really need it. Median infusions 3 and complications now, only 1% per infusion. But it's not really that easy. Sometimes we have to use alternative routes because patients have a sclerosed ophthalmic artery. In 3% of cases, we have to go with an alternative route because we had an anaphylactic response or difficult vascular access or a vasospasm. And here you can see in that article, we published the mean number of intraarterial sessions was 3, but some patients got by with 2 and a small number got by with only 1 session. But we typically only go up to 8 sessions. I know we had 1 case that had 9 sessions, but we like to stop at 8 sessions because if the tumor is not responding, you may as well enucleate. So what about intravitreal chemotherapy? Well, here you can see before intravenous chemotherapy on the top. After intravenous chemotherapy, we still have a ton of vitreous seeds. That's when we inject melphalan or topotecan to clean up the vitreous seeds. We never go higher than 20 micrograms of melphalan because it has a lot of complications. And we do like topotecan. Here you can see the fovea was intact. We've looked at intravitreous chemotherapy for vitreous seeding. It's nearly 100% successful. And here's a nice collaborative study, quarterbacked by Jasmine Francis, where we found that there were no extraocular tumor events after intravitreous chemotherapy. But these were done, all of these were done at major centers where the injections were given, and we're all super careful when we give intravitreous chemotherapy. Go through the pars plana, measure the pars plana based on patient age, inject, rinse with BSS so we don't have any seeds implanting in the conjunctiva and jiggle the eye. Now, there was a nice study on topotecan in rabbits, and they looked at 30 micrograms of topotecan, and they found no retinal toxicity. And they said that 30 micrograms in a rabbit is equivalent to 60 micrograms in a human. So now we give 90 to 100 micrograms of topotecan in human eyes, and it has resolved solid intraretinal tumor, vitreous seeds, of course, and even subretinal seeds. So we now use 90 to 100 micrograms topotecan for patients who are really with stubborn tumors that aren't going away. Like this 4-month-old girl. She had intravenous chemotherapy, then she had enucleation of the right eye, intravenous, then intraarterial in the left eye. She had this invisible tumor in her fovea. You can hardly see it, but we could see it on OCT, and it was coming back, getting bigger, 400 microns, and IAC was not reaching it. Yes, we could have done a plaque, but instead we gave her 90 micrograms intravitreal topotecan. It sat in her eye for 5 days, and the tumor shrunk down to 252 microns. So this is another alternative if IAC is not working. So what is better, IAC or IVC? Well, there are 3 concerns: tumor control, cost, and survival. Let's look at tumor control. Head-to-head retrospective studies on unilateral retinoblastoma from our team, published in APJO 2016, we found unilateral retinoblastoma IAC was better than IVC, intravenous chemo, for group D eyes. And if you look at the graph, yellow is intravenous chemotherapy, blue is intraarterial chemotherapy, and it was only significantly better for group D eyes, not for C or B eyes. And if you look at it for solid tumor, subretinal seeds, and vitreous seeds, intravenous chemotherapy is good, but intraarterial chemotherapy is much better for solid tumor, significantly better. For subretinal seeds, better. And for vitreous seeds, better. So we resort to IAC when we have these problem eyes. So this was our study, and this is important because unilateral retinoblastoma is group D or E in 75% of cases. So for unilateral retinoblastoma, intraarterial chemotherapy is the same as intravenous chemotherapy for groups B, C, and E, but it's better than intravenous chemotherapy for group D. And the team in Switzerland found exactly the same. In fact, they looked at unilateral sporadic group D eyes. And what did they find? They find that not only does group D eyes do better unilateral with IAC, but they have a shorter treatment period, better ocular survival, and better visual acuity than those treated with first-line intravenous chemotherapy. So keep this in mind. And then a study came out from China where they looked at a randomized study of unilateral group D or E, 143 eyes. 2-year control in IAC eyes was 53% versus 27% in intravenous chemotherapy. They still had marrow suppression, ophthalmic artery occlusion, and stenosis. So it comes with its problems, and we have to keep that in mind. I was a little bit surprised they had 96% survival, so they had 4% death in both groups. So they're probably trying to save more advanced cases than we might save here in the US. These are only 2-year results, so we have to wait for longer results. But at what cost? Because intraarterial chemotherapy is expensive. And a nice editorial was written by Santosh Hanavar, Indian Journal of Ophthalmology 2023. He compared the cost of enucleation in India, $600 or less, versus the US. Not sure where he got this amount, $48,000. I think it's far less than this, but I do trust his research. And then intravenous chemotherapy, India, $240 or less versus $17,000 in the US. And intraarterial chemotherapy is very expensive in the US. And I screenshot this from his report. In India, in US dollars, IAC might cost $2,000 versus $40,000 in the US. And I know some centers where it's even more expensive than that. So there's many costs that we have to consider, and he made suggestions. Dr. Hanovar suggested, hey, listen, not every center needs to do IAC. Let's just have regional centers of excellence that do IAC, and I totally agree with him. And he also said, let's bring down the cost of the hardware. I 100% agree. And let's get financial support, maybe from the government. And I also agree with that. And this study was published. This was a COG, Children's Oncology Group, published this recently in one of the pediatric blood and cancer journals in 2023. And they showed that even when you have a COG study looking at intraarterial chemotherapy, only 2/3 of the cases can the neurosurgeons or interventional neuroradiologists catheterize the ophthalmic artery. It was not feasible. So Chantada wrote this editorial, and he said, IAC is not for everyone. He said, just like Dr. Hanovar said, we should centralize IAC to centers of excellence. He said the study by Chintagu Mapala showed that it wasn't feasible in all centers, and there were complications during catheterization. And we were one of the centers, and there were complications. And he also said, if you have a small number of cases, do not do IAC. Send them to centers that do a lot of cases, because there is a steep learning curve with IAC. He wrote an entire editorial on this topic, and I do agree with him. Now, survival. Well, this was a study that came out of Egypt and Michigan. They looked at the SEER database from US centers from 2000 to 2018, and they found something very sad, published in Cancer Medicine. The 5 and 10-year relative survival trends declined between 2000 and 2018 in the US. If you look at this, survival back in year 2000 was 98%. It declined to 93% in 2012. That would be, if we had 98% survival, only 7 deaths in the US. But if you have 93% survival, that's 24 deaths. That is not acceptable. And they found it was seen with unilateral and with bilateral cases. And I'm not going to go through all the details, but in their discussion, they say some centers are trying to be super heroic and pushing intraarterial chemotherapy until the baby dies. We've got to stop that, and we have to enucleate eyes. And they also said, if you have only small patient volume, don't use sophisticated salvage measures, either enucleate or refer the patients. They made a lot of important points, and they concluded that the survival trend had declined, and maybe this is related to more heroic measures that maybe we should be enucleating more often rather than pushing IAC. So I'll conclude with an Ann Leahy editorial in the journal Ophthalmology. Ann Leahy was our pediatric oncologist. She was an awesome pediatric oncologist, very bright, and many times she would call me on the phone and she would say, Carol, this kid, the tumor in his eye is too advanced, just enucleate. And so I would enucleate. This editorial was, let's make retinoblastoma a 0-death cancer with survival rates of more than 95% and limiting the number of cycles of chemotherapy before enucleation and appropriate use of adjuvant therapy. We can move towards a future where nobody dies from retinoblastoma. It is a 0-death cancer. So within reason, enucleation for eyes with optic nerve or choroidal invasion should be done. And within reason, enucleation of eyes with unreliable parents should be done. And intravenous and intraarterial chemotherapy are wonderful, but not all patients can have them. So I'd like to thank you for giving this talk on retinoblastoma 2024 from the laser-focused retinoblastoma team in Philadelphia. Thank you.
Thank you so much, Dr. Shields. I think this was a very, very important talk because wherever we talk about retinoblastoma, mostly people try to highlight that it is time that, IAC takes the forefront, or we have intravitreal chemotherapy and targeted therapy coming in for retinoblastoma. But what you highlighted is the real world evidence that is there, that we can see. And, when it's important to decide to enucleate the eyes. So I think thank you very, very much for that. Does anybody have any questions or comments for her?
Yes, I would like to add, thank you, Dr. Shields, for changing the entire pattern in the past 30 years. You have revolutionized how the way retinoblastoma gets treated worldwide, and worldwide people are able to follow the parameters that you have highlighted and outlined. And as you have shown that it is important to even keep in mind what's the family like. It's important to keep all the parameters, not just how it presents, whether it's unilateral or bilateral, but we should look at the social aspects as well. It's very important to keep that in mind, the family aspect and how the parents are responding to the treatment. Everything should be kept in mind. And as you have also highlighted that intravenous chemotherapy is preferred for the bilateral cases, we follow the same for all the cases, even in developing countries. And even in IAC, you have shown that group D, that is an advanced, towards the advanced category, has shown 55% vision salvage. So I think a lot has happened over 30 years, and this is 2024 now.
Thank you. Thank you. Dr. Ferouz, I see you online, and I'm so happy to see you.
Yeah, I'm so happy, and it's an excellent presentation. Well, as usual, I'm extremely sorry. I'm in one location of Kerala where the reception is so bad, so I'm trying my best to log in. I was supposed to reach the city, but everything got delayed, and I'm stuck here, and I'm so sorry. And yeah, amazing presentation.
Well, we have learned a lot from you, Dr. Ferouz, and I'll never forget your major review article in Indian Journal of Ophthalmology 2021, I think, where you reviewed intraarterial chemotherapy, every study that was done. Those review articles are really important to put a treatment modality in perspective. So thank you.
I remember when I was writing that article, I also did a SWOT analysis, why it should be done, why it should not be done, and where it should be done. And that's exactly what you highlighted today. And I think it's so very important for the world to know, the indications. Thank you so much.
You're
nice
welcome.
to see you. Yes. I have requested Mritika to play my recorded video because if there's a technical glitch, I might be the reason for the delay. That's why.
Yeah. So I will play her video here. Dr. Ferouz is a consultant at Horus Eye Hospital in Bangalore. And let me just share my screen to play her video. Give me a second.
Thank you, Mritika.
Yeah. Yeah, give me a... Yeah, got it. So, yeah, are you able to see that?
We can see your screen.
Okay.
I think it's ideal to unshare it and then share that screen once again, because it's showing your folder screen right now.
Okay, give me a second. Yeah. Is this visible?
Yes. Yes,
All right.
perfect.
Okay, so I'll start playing that. I think one of the slides which Dr. Shields showed that after 20 years, still the effect of intravenous chemotherapy remains as it is. And I think that is important for us in the developing countries. So we have Dr. Ferouz talking to us about the scenario of retinoblastoma in India in 2024.
Good evening to one and all. Thank you for having me here. Thank you, Dr. Santosh and AIOS, for this opportunity in sharing this platform. And I'm extremely happy to have Dr. Carol Shields here today with us to share her experience in retinoblastoma. And so am I, sharing my experience in India in 2024, where we all know that the phase of retinoblastoma, the management has evolved tremendously from the past, and that's exactly what we're going to hear today. I'm extremely grateful to patients and parents and my mentors who have been together in this journey. So what has changed from when I started in 2015 to 2024 is the list of doctors and the list of organization and the collaborations that I'm into. So it's a very positive thing that there are bigger teams and many organizations which has come forward in the management of retinoblastoma. And one thing which is very, very constant has been ICSHA Foundation. Extremely grateful to them for funding all the patients, extremely those who comes from a very, especially those coming from a very poor socioeconomic background where patients are given complete free treatment to complete the treatment of retinoblastoma. And I think it's very important to acknowledge and be grateful to the researchers who have actually introduced what retinoblastoma is to the world and various management modalities. As we all know that the global burden of retinoblastoma is 8,000 cases per year. And what is more alarming is that India has the maximum number of cases of 2,000 cases per year when compared to United States, which is 200 to 300 cases per year. What is important about India is it's classified as a lower middle income country according to the income level with the World Bank Group. And what is important being a low middle income country is, as evidenced by various studies, that we have major challenges. The challenges that we face is in India, especially, it's a growing population. It is the most populated country in the world with 1.4 billion people. Affordability is a concern, accessibility to healthcare, retinoblastoma treatment centers, health reforms, which is not too progressive, and eye screening of these children in a baby checkup has also been, challenges that we have been facing in diagnosis of retinoblastoma. Now, when we ask the question whether there is an increase in cases, do we see an increase in cases? Yes, we do see increase in cases. Now, what is important statistically that we see here is, which is a good news, the infant mortality rate way back in 1996 was 75%, where it has improved to 25% in 2024. So we have a booming population and we have a reduced infant mortality rate where we are definitely going to see more cases of retinoblastoma in this scenario. Coming to the clinical presentation in India, most common is white reflex, but most important thing is the median age of presentation is much more, 32.5 months when compared to 14 months in the West. We do have delayed diagnosis, and that is definitely a challenge. It's unfortunate that the mean duration from symptom to diagnosis in these children is reported in our series. This is from my study, which is 6 months, where there is a delay in diagnosis from the presentation to the to seeking treatment in a specialist center. And this is how they present with ophthalmos and proptotic eyes. Now, 19% of these children were initially seen by the pediatrician and then later referred to the ophthalmologist. This child was a case of unilateral retinoblastoma who presented as at 3 years of age, where he did have white reflex when he was 18 months of age. And that was how there was a delay with advancement of the disease and progression to an intracranial extension. And this is a fact. And, the everyday challenge that we face as retinoblastoma specialists. So the most common presentation is leukocoria, and proptosis is around 5%. So I just went back and compared with the historical data, which I collected when I was a fellow, and that was 11 years back, 2010, and still there is not much of a difference in the clinical presentation 11 years back to now. So the most common group that we see is group E, which comprises of 55%, and followed by group D, which is 26.5%. And this is the TNM classification. I'm not going into the details of it. So compared to the historical data, again, there is not much of difference from 11 years back to now, where group E was 43% in the historical data here. Extraocular extension of retinoblastoma in my practice is is 6%, but there are reports from other treatment centers of India where it is as high as 20%, and this is definitely an unfortunate situation where these patients come with advanced diseases like this. So the diagnostic challenges of retinoblastoma in 2024 is delayed diagnosis, misdiagnosis, and advanced disease. So as far as the solution is concerned, it's very important to increase the social awareness campaigns, educational activities among the public, while making the treatment more affordable, accessible, and might help us to close the care gap. And I think a public health system has to take the initiative in collaborating with the retinopathy specialists from different parts of the country and making it feasible, the treatment feasible for these patients from the lower economic strata. Continued medical education and referral of these patients to a retinoblastoma specialist in a retinoblastoma center timely would actually help us avoid misdiagnosis. And I think as ophthalmologists, we all are responsible for these children and their lives, the eyes and the vision. So these things have to be taken care as a solution. Retinoblastoma diagnosis is not too difficult. It is a clinical diagnosis. You don't need too many fancy diagnostic tools to diagnose retinoblastoma. The child has to be under anesthesia. A detailed evaluation of the anterior segment, the posterior segment, including the ora serrata, 360-degree with the limited resources is good enough for a meticulous examination and documentation of retinoblastoma. As far as treatment strategies of retinoblastoma in India is considered, we have all the treatment from systemic chemotherapy to the most advanced intra-arterial chemotherapy center in India. And we have very well-trained retinoblastoma specialists in different parts of India who are well-versed in intraocular chemotherapy and various modern treatment in retinoblastoma. There are centers, limited though, where they are well-equipped with laser therapy, cryotherapy, and plaque brachytherapy in India. So we have 11 centers which is full-fledged equipped for intra-arterial chemotherapy and 9 centers with plaque brachytherapy in India. And these are the treatment centers where there is a little bit of a geographical disparity between the south and the north in the number of centers. So systemic chemotherapy is still the favorable treatment modality in India because it is time-tested, it is cheap, it is affordable and accessible for patients in most of the cancer centers. This is how a group A disease was treated with a laser therapy, and this is a group B with phobia sparing treatment with systemic chemotherapy where the complete tumor regression has happened now. These are cases where cryotherapy comes into help, where I often combine cryotherapy with intravitreal topotecan nowadays in my cases, where a cryo to a peripheral tumor with topotecan injection with one session, it completely regressed. And this is cryotherapy and topotecan 3 sessions where a large tumor regressed with cryotherapy alone. Plaque brachytherapy is also done, and the happy news is it has become more affordable for most of the centers, and that's why we have 9 centers in India at this point, because the Baba Atomic Research Center of India, we develop ruthenium plaques, and this has become very, very affordable for most of us to acquire. Now, so various treatment modalities and various combination of treatment modalities has helped us to save more eyes and vision, as in this case where group B disease in this older child full of vitreous disease, endophytic RB, well, ciliary body involvement, and where she had to undergo systemic chemotherapy, periocular topotecan, intravitreal topotecan, and plaque brachytherapy to get a 6x6 eye after, the journey of all this combination treatment. Intra-arterial chemotherapy, we do have centers. We have excellent experts who are interventional neuroradiologists who take initiative in doing these cases, and we have very good results. And this is my oldest patient, 15-year-old, who had a retinocytoma activation, and she had undergone intra-arterial chemotherapy. Enucleation in retinoblastoma is still practiced in India. It's just not how the intraocular disease is advanced. We also take into consideration various socio-economic criteria in these children and the parents, where sometimes affordability and reaching out for further follow-ups might be difficult, and finally we decide on enucleation. But the counseling is so has to be so important. Counseling is so important, where we actually promise the parents in order to convince them that we will be providing a near natural looking eye by giving a customized ocular prosthesis, and we do keep our promise. We have excellent ocularists who deal with customized ocular prosthesis, giving this kind of appearance to our children. So when we talk about enucleation, uniformly in most of the retinoblastoma treatment centers, we follow the same protocol of minimum manipulation enucleation with long optic nerve stump and meticulous pathological evaluation of these patients to identify histopathological risk factors, whether to plan on further management with chemotherapy as far as life salvage is concerned. So as far as treatment challenges are concerned, we do have social beliefs, which is a big hindrance to treating these patients. Some patients defer treatment, and of course, financial constraints. Financial constraint to a certain extent is taken care by foundations like ICSHA and CAN-KIDS and various government schemes which help providing treatment to these patients free of cost in most of our centers. Well, so coming to social belief, this was a child with bilateral retinoblastoma, treated, advised enucleation for the worst eye with ophthalmos. When they heard the word enucleation, they just were lost to follow-up. After 9 to 10 months, they come back where they have gone for an alternative medicine, and which is prevalent in India, and the child came with intracranial extension. So these kind of beliefs are very, very difficult as far as an retinoblastoma specialist perspective is. Now, as far as genetics in India is concerned, we are reaching there. Well, there is a long way to go when compared to the West, the kind of work that you do. We do still have very limited resources as far as research funds are concerned, affordability of the genetic tests as far as patients are concerned. We do have full-fledged 7 centers of retinoblastoma genetic testing in India, and we have few more centers which is actively working through. So the overall survival of retinoblastoma in India is 94%, which is good. In intraocular retinoblastoma and extraocular retinoblastoma, where with the intensive multimodal treatment protocol, and this is the updated one with 44% of primary orbit, we are still able to get 95% survival in these patients. And this is a very nice article published by Swati Kalki, where in detail she has taken into consideration each and everything about retinoblastoma in India, and even in that paper, the overall survival was 92%. So coming to the take-home message, retinoblastoma is a curable eye cancer. We do have red flags like delayed presentation, advanced disease, accessibility, affordability, and social beliefs, which we have to take care, unified and taking care of this situation. But we have many green flags, such as we have excellent trained retinoblastoma specialists. We have so many young people coming up with equal passion in this field, well-equipped facilities, advanced treatment centers, and the gray zones are the referral system where the general ophthalmologists and doctors have to recognize and realize that this is a lethal disease, and these patients have to be referred to a retinoblastoma treatment centers, which is completely equipped in order to get appropriate management and reduce misdiagnosis. Well, public health system initiative will make it affordable. We are working on it, and eye screening programs for early detection will be definitely helping us to get through certain challenges. So together, Future in Retinoblastoma is that our effort is always to save life, eye, and vision. Thank you so very much for your patient listening. Thank you.
Thank you so much. If it's okay with you, Dr. Shields, I'll move on to the final presentation and then take the discussion in the end if we have the time. Okay, so now we have our final presenter, and I'd like to invite Dr. Irwin Leventer, who's a research intern at Wills Eye Hospital currently, and he'll be talking about the role of 5-FU in conjunctival squamous cell carcinoma.
Thank you so much for having me. It's an honor to be here. And thank you to all my mentors leading up to this. And a special thanks to Dr. Shields for your mentorship every single day this past year. I really appreciate it. I'm going to be speaking about the role of 5-fluorouracil 1% in the management of conjunctival squamous cell carcinoma. Here we go. So your patient comes in and says, hey, doc, I think I have eye cancer. And you take a closer look, and here's what the patient's eye looks like. Talk about tumors to the forefront. And this looks scary. What are you going to do for this? Imagine you can just say, no problem, take some eye drops, and pass some eye drops over and get resolution like this. So that's what we're going to be talking about today. Ocular surface squamous neoplasia is the entity we're discussing of the conjunctiva and corneal epithelium. And it's on a spectrum from dysplasia to squamous cell carcinoma in situ to invasive squamous cell carcinoma. Incidence of 0.03 to 1.9 per 100,000 per year. And risk factors including UV exposure, smoking, chronic trauma inflammation, immunosuppression, skin cancer, vitamin A deficiency. So in terms of treatment, the standard of care has been no-touch surgical excision and adjuvant cryotherapy. And here are some alternatives. Interferon eye drops, mitomycin eye drops, and 5-fluorouracil eye drops. Let's talk about each of them in turn. Interferon eye drops, pros being that it's a reliable immunomodulatory topical agent for OSSN and has the least epithelial toxicity of the 3 eye drops we're discussing. The cons being that it's been discontinued in the United States by the sole supplier, and therefore it's unavailable to us. Mitomycin C does have efficacy in treating OSSN, but the con being significant rates of epithelial toxicity. And so we wouldn't want to focus on it as much now that we don't have interferon anymore. So now let's focus on 5-fluorouracil 1%. Its mechanism is it's a pyrimidine analog that disrupts DNA synthesis. And it has been studied previously. So in 2000, Yates studied 7 eyes and found that 4 of them were disease-free with no additional treatments with 5-fluorouracil 1%. In 2011, Rudkin studied adjuvant 5-FU and found it to have low recurrence and low complications. In 2014, Barami studied adjuvant 5-FU and showed it to have low recurrence and few complications with less need for intervention in comparison with mitomycin C. In 2019, Venkatswaran studied 5-fluorouracil and interferon, and both had high resolution and low recurrence rates. And finally, in 2023, Wailigala studied primary 5-FU and showed it to be safe and effective for OSSN. And importantly, we learned a lot about 5-FU for OSSN, but we know about adjuvant use of 5-FU, and we know about its use as a primary treatment. But now we want to talk about its use as primary versus secondary treatment, because it is our best agent available, best topical agent available for OSSN. So we need to learn more about it. So this is a retrospective review of medical records, 73 consecutive patients between 2016 and 2023. And they were all diagnosed with moderate to extensive OSSN. So the important thing about the study is that it's comparing primary versus secondary 5-FU, and it's specifically looking at moderate to extensive OSSN, defined as greater than 12 millimeter basal diameter at the limbus or greater than 3 clock hours of fornicel or tarsal involvement. And this is quite an extensive picture, but this is the kind of extensive tumor that we're talking about. So statistical methods, pretty standard. Descriptive statistic computed for continuous variables. Independent 2-sample t-tests, chi-squared tests of independence, and Fisher's exact tests for categorical variables. Multivariable analysis, p less than 0.05, statistically significant. And in terms of demographic features, there were no differences between the groups. In terms of clinical features, no differences between the groups. Again, more clinical features. In terms of treatment features, no differences. Both groups, primary and secondary, had the same number of weeks of active 5-FU therapy. And the most important thing is in clinical outcomes. Patients who received primary 5-FU were more likely to have complete tumor control, 77% versus 38% in the secondary group. And they were less likely to need additional treatment, i.e. surgical resection, 12% versus 44%. And so again, just to summarize, primary treatment had greater complete tumor control, less need for additional surgical resection, and multivariable logistic regression confirmed primary treatment more likely to achieve complete tumor control. Some future studies that we would want to look at, we would want to be obviously repeat with longitudinal follow-up to make sure that recurrence rates stay low. We would want to study a comparison between IFN and 5FU in terms of their efficacy, and also a cost analysis in the hopes of maybe bringing back interferon into the United States. And finally, genomic and biomarker predictors of treatment response so that we can tailor and choose agents that are specific to our patients, which is the future of medicine. And so our take-home points today, of the topical agents for OSSN, only topical 5FU 1% is both available in the United States and has low complication rate. 5FU given as primary treatment for OSSN is more likely to achieve complete tumor control versus secondary treatment. And there's more to learn about the role of topical agents in the fight against eye cancer. And finally, the take-home point that we saw at the beginning, getting eye drops to treat eye cancer would be a beautiful thing. And thank you very much. And here are my references.
Thank you, Irwin. I have to congratulate you on this excellent presentation. I think we saved the best for the last.
And beautiful animation there.
Yeah, I would
Thank you.
totally agree. You know, Irwin, if we have a small OSSN, we'll just resect it. It's fast. Patient doesn't have to buy drops. In and out, same day surgery, easy. But your study was on big OSSN. Like that first case you showed, it was the whole conjunctiva. We're not going to resect that. So, even though your numbers weren't huge in this study, you showed something really important, that OSSN, if you use it as a primary treatment for large, if you use 5FU as primary treatment for large OSSN, you're going to be successful in most cases. Yeah, really important study. Is that going to be published?
Yes, in Asia Pacific Journal of Ophthalmology.
Great. Yeah. APJO is coming out with a Ocular Oncology special edition, I think in a month or two. Rollick is working very hard at getting some papers into it, and Irwin's paper was accepted. So that should be a very interesting one. And also, just so you know, the Canadian Journal of Ophthalmology, I think this month, it came out with multiple ocular oncology papers. It's their special edition.
I think we'll all go back to that. But I think this was a wonderful session. I'd like to thank all our presenters.
May I ask a question to Dr.
Go ahead.
Feroz?
Yeah, go ahead.
Dr. Feroz, are you online there?
Yes, I'm there. Am I on?
Yes, you are. Yes, you are. We all know, as we all know, that you have been able to provide your care and your services in United States and in China and in India, and you've seen different countries in terms of social aspects and economical aspects. What would be the one difference that you would highlight and say that was strikingly different in all the countries in terms of social aspects?
Well, Ronika, my experience in United States has been great, and that is with Dr. Carol Shields. So I think the accessibility of care, and the main centers taking care of retinoblastoma children is something which is very, very advantageous. Where in countries like China and India, I don't find there is.
I think her reception
difference in the social aspect as such.
Dr. Feroz, are you still with us? All right.
I think we're losing, reception.
We're
But
losing.
I think she pretty much said access to care is different. And access to care in the US used to be a phone call. They would dial up our phone, get our secretary would come back with a sheet, we would fill out everything. It's not that anymore. Now, access to care in the US is a text or an email. And Rollica knows this very well, and so does Deepthi. It'll come in, and then what I do is I will forward it to our registration, and I'll forward it to our fellow, and I'll forward it to the EUA person so that we get the patient in as fast as possible. Usually within a week, we can get them in.
Right.
I think we saw a wide range of tumors, and we discussed a lot of interesting cases. Just to end on a positive note, I think what's important is that all of us are working together and working hard against a lot of ocular tumors. In terms of accessibility, what Irvin highlighted, 5FU is something that is affordable and accessible to everyone. In retinoblastoma, what Dr. Shields highlighted was that the efficacy of intravenous chemotherapy that's available to everybody is really good, especially in B, C, and even in terms of E with respect to IAC. So it's only D where we see the difference, the main difference. But at least we can treat the patients that we see with what we have available. So thank you very much for, yeah. Go ahead, Dr. Shields. I think
I would like to say one comment on what Dr. Faru said.
Mhm.
She said there's a lot of young people interested in ocular oncology. And I'm looking at all of you right now. And I think it's wonderful because you guys are going to write the next chapters in the field of ocular oncology. We're here to guide you, and you're all running with your interest, and I think it's really important. So I'd like to thank all those of you who have done fellowships or internships with us, because you're taking that education and you're going to apply it in the future.
thank you
And we are
so
happy
much
to
for
learn that from you.
always being our mentor. We'll just take a group photo quickly.
Yeah.
Yeah. All right. I'll take that. And got it.
Okay.
So, Mritika, you have done my one job of taking the official photo, but never mind, I have also taken it. So, I would like to thank Dr. Mritika for moderating this session so very well. I would like to thank Dr. Shields for her valuable time and inputs. I would like to thank all these speakers who made lovely presentation. I really enjoyed, though I'm not an oculoplastic person, but I really enjoyed being in this session. So a quick announcement for our audience. We have tomorrow the last day of the conference. We'll have our first session starting at 10 a.m. sharp, which will be on trauma. So do join us. Good night, and those who have still morning, enjoy rest of the day.
Thank you so much.
Thank you.
you.
Connected.